Welcome to another CME podcast episode from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Karl Doghramji about best practices for the diagnosis, treatment, and management of insomnia. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Doghramji discuss the challenges and evidence-based strategies for the pharmacological treatment of insomnia.
Hello and welcome to another NEI CME podcast. Today's podcast is entitled Wide Awake, an update on best practices for the diagnosis and management of insomnia. And with me today, I'm really excited to have really one of the world's true authorities on this topic, Dr. Karl Doghramji. Karl, how are you today?
Great, Andy. Good to hear you.
Yeah, it's good to talk to you. And Karl and I were just talking a minute ago. We share the home city of Philadelphia, actually, and we were just comparing notes there. We didn't quite talk about where to get the best cheesesteaks, but we can talk about that later, I think, Karl, if that's all right.
Highly controversial point, yes.
It is a controversial topic. Well, today, of course, we're going to be talking about not only assessing insomnia, but also treating insomnia. And we're going to get into some details on some of the different options that are out there. But first, I just want to remind people that we're going to talk about how to assess insomnia and even if there's any kind of tools or tests that we can use. So why don't we just get started? Insomnia, Karl, is such a common problem. How should clinicians think about categorizing it or just think about approaching insomnia?
Absolutely. And as you point out, it's very common. In fact, it's probably the second most commonly voiced human complaint. When you think of all medical complaints throughout the course of one's lifespan, there is about a 30 to 50% possibility of experiencing insomnia. So it is quite common. Now, certainly we can conceptualize insomnia as being both a symptom as well as a diagnostic entity or disorder. From a symptomatic standpoint, really the best way to identify it is simply to ask the patient, do you ever have difficulty falling asleep, staying asleep, or waking up too early? These are, by their very nature, the definitions of insomnia as a complaint. Nevertheless, the disorder is identified by a constellation of symptomatic manifestations. There are two diagnostic categorizations of insomnia. One is the International Classification of Sleep Disorders, and the other is the DSM, or Diagnostic Statistical Manual of the Psychiatric Disorders. And in both of them, there is certainly patients have to have the symptomatic manifestations, difficulty falling asleep, staying asleep, waking up too early, having an unrefreshing quality to their sleep, but also having some degree of daytime impairment associated with insomnia, such as fatigue, malaise, social dysfunction, mood disturbance, daytime sleepiness, and so on and so forth. And then finally, there is a time course associated with the diagnostic nosology that the difficulty has to exist for more than 3 months and also has to occur around 3 times a week or more. So that describes the diagnostic aspect for insomnia.
So it sounds like if somebody sleeps, let's say 5 to 6 hours a night, but they're not bothered by that, that would not be a disorder, obviously.
Yes, definitely not. And that's something which some people do. Some people are lucky enough to have a short sleep need. And really the best way to assess whether or not that need is adequate for that person is to really look at daytime functioning. So is he able to stay awake all day, not fall asleep during important activities? Cognitively, is that person functioning well, and so on? So that time period may be too short based not only by virtue of having an insomnia, but based on the sleep deprivation, which is actually quite common as well, where even though we have the ability to sleep longer, we deprive ourselves of the opportunity to sleep longer. That's different from insomnia.
I see. Mm-hmm. And so how should we think about evaluating? What are some of the tests, some of the diagnostic scales that we would use?
Yeah, so once insomnia is identified, the question becomes, can we more accurately define it? Mm-hmm. And there are a number of scales. One of the most commonly used ones is the Insomnia Severity Index, or the ISI, developed by Dr. Marin in Canada. And it's a 7-item questionnaire which asks about not only difficulty falling and staying asleep and waking up too early, but the degree of satisfaction with sleep, lessness, and also to what extent does this problem interfere with daily functioning, how noticeable is it to others, and how distressed is the person as a result of having this insomnia disorder. And any score of greater than 8 is considered to be significant. Another scale commonly used is the Pittsburgh Sleep Quality Index, or the PSQI. That also gets to the heart of the matter, which is the quality of sleep. And it's also related to not only measures of sleep patterns and so on and so forth, but also to what extent does this affect daytime functioning. What's interesting about both of these scales is that even though they look at sleep quality in general, they also ask a question or two on how does that individual function during the course of the day. And that's something which has been really missed in many of the older scales. And when we look at the scales being developed currently, one interesting one is the Insomnia Daytime Symptoms and Impacts Questionnaire, or the IDSIQ for short. That's a scale which looks specifically at daytime functioning of insomniacs, which is kind of a novel way of looking at insomnia. Well, we talk about people not sleeping well, but how do they function? And this scale focuses simply on that aspect and divides up the dysfunction into 3 domains. One domain is the alertness cognition domain. The second is the mood domain. And the third is the sleepiness tiredness domain. So these are some of the commonly used scales for insomnia.
I believe the IDSIQ was used in the clinical development program for the most recently approved insomnia drug, daridorexant. Am I correct?
It was, exactly. And that, to the best of my knowledge, the only medication to be recently introduced that has utilized a daytime functioning scale prior to its introduction.
Yeah, so not just measuring sleep itself, quality of sleep, but the consequences the next day, so the functional outcomes.
Precisely.
That's super. I've done clinical trials. We've often used the Pittsburgh Sleep Quality Index, and sometimes we use the Epworth Sleepiness Scale, the Epworth Scale. Where might a clinician use the Epworth Scale?
Yeah, the Epworth is probably more relevant for patients who are very sleepy during the day, such as narcoleptics, sleep-deprived individuals, and apnea patients. One of the issues with insomnia is that insomnia itself seems to be a disorder with a high degree of internal activation. So this sense of hyperarousal characterizes many insomniacs. So even if they may be sleepy or tired during the day, they don't really fall asleep readily during the day. And the Epworth assesses the propensity of patients to actually fall asleep during daytime activities. So many insomniacs don't score very highly on that scale, and so it's not as relevant for this population.
Well, that's really helpful. I think we did jump over one quick thing, which is, of course, ruling out other conditions. And certainly we've got a lot of mental health practitioners listening to us. I would say, of course, depression and anxiety would be the 2 most common psychiatric things we'd have to rule out, maybe substance abuse, things like that.
Oh, definitely. And that brings up the point, of course, that their insomnia is characterized by a very high degree or high proportion of comorbid disorders, mental health disorders, as you pointed out, neurologic, medical disorders, and so on. Yeah, absolutely. So a very thorough medical psychiatric evaluation is important. And certainly when primary sleep disorders are suspected, such as sleep apnea or periodic limb movements in sleep and so on, a sleep study would not be inappropriate to rule those out. I think also in cases where circadian rhythm disturbance is suspected, such as delayed sleep phase disorder, advanced sleep phase disorder, actigraphy is relevant. And this is a wristwatch type device which monitors motion and which can quantify the sleep and wakefulness indirectly and therefore give us a good sense of one's sleep patterns over long periods of time.
Well, that's really helpful. And that was going to be one of my questions. When should I think about doing a sleep study? Should I be routinely doing a sleep study in all of my patients with insomnia, or is that too broad?
I think it is too broad. I think certainly the patients who have, as I mentioned before, disorders which clue us into a primary or a sleep disorder, like apnea. For example, the symptoms of apnea include snoring, gasping during sleep, gaps in sleep during sleep, those sorts of things. Periodic limb movements are characterized by twitching of nocturnal limbs during the night. Those types of things might be more relevant in terms of a sleep study.
Narcolepsy as well, I would think.
Very definitely. So not commonly seen with insomniacs, but certainly the patient who has daytime sleepiness, falling asleep readily during the day, may have cataplexy, which is some loss of muscle control during the course of the day after laughter or anger. That person may be inappropriate for a nighttime sleep study and a daytime multiple napping test, which is one done in the sleep lab.
Okay. Yeah, you've just pointed something out I think that's really helpful, Karl, and that's the distinction between insomnia versus EDS, or excessive daytime sleepiness. They're not the same exactly. There's some overlap, of course.
Very much so, yeah. EDS is the tendency to fall asleep, or the exaggerated tendency to fall asleep during the course of the day. And people who are working but fall asleep at their computers or while driving, by definition, that is excessive daytime sleepiness. So even though we may feel fatigued and run down and slowed down, we may not necessarily be sleepy. And the Epworth scale, which you talked about before, can better get us to the point of deciding, is this truly sleepiness or not? But in insomnia, we find people who are fatigued but don't necessarily fall asleep during the course of the day. So they're technically not sleepy as such.
I see. So we're going to focus on insomnia, of course. So what would you recommend then? You've got a patient complaining of insomnia. We've maybe ruled out depression or other medical conditions. What would you do next at this point?
Certainly I think it's very relevant to start asking insomniacs about, we talked about comorbidities and so, but also starting to get a sleep pattern. What is the pattern of their sleep in terms of each night? Is it a problem falling asleep, staying asleep, waking up too early? That can help us in terms of differential diagnosis. As an example, a person who has difficulty primarily falling asleep, not falling asleep until 2 or 3 in the morning, may have a delayed sleep phase disorder. Or maybe a person has an anxiety disturbance, whereas a person who falls asleep, let's say at 8 p.m. and wakes up early in the morning may have a more of an advanced sleep phase disorder, just as an example. The time course of sleeplessness during the course of the night may also help us identify which patient may be appropriate for which medication later on, if we do decide to go with medication. So there are some medications that are indicated for difficulties with sleep initiation, whereas others are indicated for difficulties with sleep initiation and maintenance, or difficulties staying asleep. And some medications are indicated for both. So this might be something to ask about. And certainly I do think also it's not a bad idea to begin to dig at what types of other things may be going on in terms of metabolic and endocrine disturbances. So a good set of lab tests, a CBC, a metabolic profile, maybe a thyroid level may not be a bad idea as well if a person hasn't had those done for the past year or longer.
Yeah. I guess you would also want to assess caffeine use, nicotine use, things like that.
Habits are so important, aren't they?
Yes.
Yes, absolutely. What do you do for the hour or so prior to going to bed? Some people have this exposure to light-limiting devices, their telephones and their smartphones and so on, which may help them get their minds off of sleeplessness and off of the worries of the day, but may be problematic in terms of shifting sleep rhythms in the wrong direction because of the amount of light that they emit. How much noise is there close to bedtime? When you wake up in the morning, do you keep the shades shut and stay in your bedroom, or do you get out and expose yourself to lots and lots of bright light? How much napping do you do during the day? Are you active? And when do you exercise? Is it too close to bedtime, which may be problematic for sleep, or is it well prior to bedtime? Yeah, those sorts of questions may be very relevant.
Yeah, certainly. So it sounds like the old thing that we all know, sleep hygiene, needs to obviously be preached and evaluated.
Yeah, very much so. It's kind of surprising, Andy, how many people benefit just by simple, I call it simple, but sometimes not so easy to exercise, but by changing their behaviors relative to sleep and wakefulness along the lines that we just talked about.
I have a 17-year-old son, and I can tell you he likes to play his video games, and that clearly keeps him up at night. So I understand what you mean nowadays. Yeah. These devices and screens and light coming into the brain. So now we're ready to think about intervening here. And my understanding is that actually cognitive behavioral therapy is the first recommended intervention.
It certainly is. Many of the societies that have something to say about insomnia, the American Geriatric Society, the American Academy of Family Physicians, certainly the American Academy of Sleep Medicine, all these societies recommend that we first consider CBT, or cognitive behavioral therapy, for insomnia for a couple of different reasons. Number one, it certainly is just as effective in the short run as pharmacologic therapy. But in the long run, that is, in terms of long-term duration of effect, it's superior to pharmacotherapy. So by treating somebody for insomnia now with CBTI, we have a much better chance of helping them for years to come after the termination of therapy compared to pharmacotherapy. Certainly from a side effect standpoint, these therapies are, CBT therapies are superior in the sense that they have really no side effects other than, of course, the inconvenience of coming to a therapist's office and that sort of thing. The issue with CBTI really is that the availability of therapists is problematic. There are not a lot of trained therapists. And number two, it does require a greater degree of commitment on the part of the patient in terms of coming in or having regular sessions with a therapist. So time limitations often favor pharmacotherapy. But definitely, these are preferred in more ways than one.
Of course, nowadays there are PDTs. There's these prescription digital therapeutics. There's one in particular I know that's FDA approved for insomnia. And that might help a little bit with the issue you mentioned of the availability of therapists and things like that.
Very much so. There are many online modules as well that we can download that are free, which help us with maybe some sleep hygiene issues, help us quantify our sleep-wake times. Absolutely. As many as some of the wristwatches we use now also have the ability to quantify sleep and wakefulness. Absolutely.
Yeah, I'm not a gadget guy. My wife has an Apple Watch, and she's always telling me how many steps she gets and how long she slept and things like that. So I know that people do use these things.
Well, Andy, it's a double-edged sword, isn't it? Because some people benefit from just the idea or the possibility of, by using these devices, some people benefit because it gets them focused on their sleep and helps them at least try to improve sleep in the long run. But the problem is that some people become so tied in or so watchful of their sleep that the anxiety level they begin to escalate and it becomes more difficult for them. So it depends on the kind of person, I think.
Yeah, that makes sense. Well, the idea of trying to individualize your intervention makes a lot of sense. Let me ask you a question, Karl. So I would imagine that CBTI is not mutually exclusive with medication. Could they be employed together?
Very much so. And the question really becomes, which do you use first and then which do you introduce second? And I think once you've introduced one, the addition of the second is often relevant. So as an example, a person who has started pharmacotherapy because of the fact that he or she needed rapid improvement. So CBT may take a few weeks to maybe even months to start working well, but pharmacotherapy works rapidly. So after the introduction of pharmacotherapy and the resolution or the mitigation of symptoms, CBT can be introduced as a way of diminishing the reliance on pharmacologic agents and therefore sort of catapulting the person into long-term benefit. So absolutely, the two could be intermixed.
Yeah, and certainly then take advantage of those long-term benefits you mentioned of CBTI. I think all of us would agree that we probably don't want to continue a sleep medication indefinitely forever. I mean, I know some do have indications to be shorter duration or longer duration, but probably we don't want to continue a medication if we don't need to. Is that a fair way to see it?
I think that's certainly an excellent point. Why continue a medicine if the patient doesn't need it? I think the question becomes, how does one assess the need for a drug, right, over the long run? And I think one strategy that I have is after a month or two of successful therapy, I suggest to my patients that they just diminish the dose of the medication just a tad. So, for example, 10 milligrams of a drug going down to 5 milligrams of a drug, as opposed to discontinuing it. And doing so for a few weeks at a time. Yeah, that might help us. And if the need is certainly still there, continuation may make sense, but maybe checking about the need again another month or so thereafter. So I agree. Diminishing the dose over time is very helpful. On the other hand, some people, unfortunately, do have long-term needs for these medications. Insomnia can be a long-term problem for some patients.
Yeah, certainly. We have a lot more options than we have ever had in the past for treatment. Benzodiazepines, of course, have been used historically for a long time. There are some sedating antidepressants such as trazodone, and even doxepin at low dose was FDA approved. But, probably one of the biggest generational shifts was the introduction of the non-benzodiazepine so-called Z drugs.
Right.
How do we think about benzodiazepines versus the Z drugs?
So as you know, Andy, these drugs all act at the benzodiazepine receptor complex or the GABA-A receptor complex. By doing so, they promote the activity of GABA, which is an inhibitory neurotransmitter in the central nervous system. So by doing so, they promote sleep. The Z drugs differ slightly from the older benzodiazepines in that they tend to be more selective for the subtypes of the alpha subunit in the GABA A receptor complex. And in animal models, that these alpha subunits have selective or physiologic effects. So, for example, the alpha 1 subunit mediates sedation and amnesia, whereas the alpha 2 subunits mediates anxiolysis and myelorelaxation. So the thought has been that by selectively promoting these various subunit types, one can preferentially promote certain clinical activities in humans. Unfortunately, that sort of contention has never been actually demonstrated in humans or demonstrated well. So the Z drugs seem to, at least from the standpoint of human beings, have similar effects to the older benzodiazepines clinically, but the differences may be more due to not so much the receptor selectivity, but more so due to their pharmacokinetic profiles. That is, many of them are shorter half-life agents, such as zolpidem and zaloplan. And by virtue of the shorter half-life, they may also have less daytime side effects, such as sedation and amnesia and so on and so forth, than the older benzodiazepine.
Yes, fascinating. Yeah, the GABA A receptor certainly is fascinating. It tends to be pentameric. Well, that's hard to say. It tends to have 5 subunits, a couple alphas, couple betas, and then one other one that varies.
Right.
And there's several different, as you mentioned, the alpha subtypes. And the reason we've been talking a lot about this with NEI is because there are some antidepressants in development now that are GABA A positive allosteric modulators, that are neurosteroid type drugs. So I think our audience should be educating themselves about the GABA A receptors and learning more about them.
Interesting.
They are fascinating, yeah. So there are bolded box warnings, however, for these drugs, are there not?
Yeah, definitely. These box warnings came up in the context of the Z drugs as well as the primarily. And what happened was that there were a number of cases of complex sleep behaviors that were reported over the course of the past number of years when the FDA began to do this analysis. And these were spontaneous reports, and they included things along the lines of accidental overdoses, motor vehicle collisions with a patient driving on an amnestic state, even some patients drowning while walking into the ocean, self-injury. So even though there weren't a lot of these, in the order of a few hundred, as I recall, the FDA decided that they were significant enough in terms of impact that on an individual basis that they would put in boxed warnings for all of these drugs. So basically the idea being that these drugs can cause complex sleep behaviors and clinicians should be aware of these. Now, certainly if a patient has a history of these types of experiences, these drugs are then contraindicated in that specific case for that specific patient. The question comes about, how do you mitigate or diminish the possibility for these types of parasomnia as well? The papers that came out looked at historical factors in patients, and the patients who were more likely to engage in these behaviors were ones who also used alcohol and other sedatives. So to tell patients, don't drink alcohol with these medications. So, and don't use them more than the recommended dose. So some patients were taking the higher doses. Certainly if a patient has a history of a parasomnia, a patient with a history of sleepwalking, an adulthood especially, should not take these medications. So those are some of the things that could mitigate the possibility of these behaviors from happening to begin with.
Yeah, well, that's certainly a pharmacodynamic interaction. Alcohol is also a positive allosteric modulator at GABA A receptors, so it's almost like you're overdoing it there.
Great point.
Yeah, and then certainly we know that there was a change in the recommended dosing for zolpidem in particular vis-a-vis gender, male versus female. Can you talk a little bit what happened there?
Yeah, so when doing the clinical trials with the version of zolpidem, which is actually middle of the night administered zolpidem, the data seemed to indicate that women had a decreased ability to metabolize zolpidem than men. And in about 20% of women, there was a significantly greater amount of zolpidem in the blood the next morning. So because of that, there was a recommendation that women should be limited to 5 milligrams maximum zolpidem. And also there was a similar sort of warning about the other doses of the other Z drugs.
I see. That is fascinating. Do we know why the difference? Does it have to do with hormonal issues or
Good question, Ed. I don't think I've seen anything actually about that, but it's a good question.
Well, I think that there are many examples of different metabolic effects. I mean, one of the things is that it turns out the CYP3A4, it has a lot of individual variability and especially may have some gender differences.
Huh.
And so certainly that's a possible pharmacokinetic explanation. There's also pharmacodynamic potential explanations of why women might be more sensitive, although you did mention higher blood levels. That's a pharmacokinetic issue, obviously.
Yeah. Interesting.
Fascinating. I mean, it just points out the fact that we really do need to individualize not only the choice of medicine, but our dosing. We need to monitor carefully.
Yes, very definitely.
Are there certain benzodiazepines or Z drugs that you recommend for certain situations? How do we think about choosing amongst these drugs?
Yeah, it's a good question. I think certainly when choosing a drug, the time course of the insomnia certainly is the starting point. Is it an initiation insomnia? Is it a maintenance insomnia? And certain drugs are indicated for those specific features. So as an example, for sleep onset insomnia, zolpidem, zaloplan, and a non-benzo ramelteon would be indicated. Whereas for sleep maintenance, zolpidem low dose, which is given in the middle of the night, may be indicated as a PRN drug, or Piclone, zolpidem extended release. These are effective not only for sleep initiation, but also for maintenance. So in terms of the Z drugs, those are some of the branch points. But in terms of are any of them specifically more relevant than others for other categories of patients, and it doesn't seem to, because they're all benzos, and really not much. I mean, certainly if a patient is a older individual, using the lowest effective dosage would be relevant. And I personally err towards the use of the shortest half-life agent, such as zaloplan, for example, if I'm going to use those three agents for an older individual. But so those are some considerations.
Yeah, that's extremely helpful. Thank you. I was always fascinated that some of the benzodiazepines that were approved for insomnia actually had quite long half-lives. I was wondered about that.
Yeah, the older benzos, especially if you're referring to those. And yeah, I think one of the issues is that a long half-life doesn't necessarily mean long-term clinical effect, right? Mm-hmm. So some of these longer acting benzos, even though they do stay in the system for a fairly long period of time, may not necessarily have that detrimental an effect when it comes to cognition, although many do. Yeah. But some do not. So, but I think your points are very well taken. If there is any risk of daytime impairment, I would certainly err towards the use of the shortest acting agent.
Yeah, historically, I've always used alprazolam or lorazepam for sleep, just out of, I guess, comfort or familiarity, more than some of the longer ones, like temazepam, for instance, or something.
Right. Or clozapam or something like that.
Yeah. Well, now, of course, we have a whole new category of medications. That's the orexin antagonists, the so-called DORAs, the dual orexin receptor drugs. What led to their discovery? Where did they come from?
Yeah, good question. So, yeah, as you well know, the whole system of sleep and wakefulness is governed by a complex set of neurotransmitters. On the one hand, there are these wakefulness-promoting neurotransmitters such as histamine, serotonin, acetylcholine, dopamine, and so on. And then there are sedating neurotransmitters, and the ones that are more integrally related to sleep include GABA, or gamma-aminobutyric acid, and galanine. So the balance between these sedating and wakefulness neurotransmitters is what determines whether an individual is asleep or awake. Now, it turns out that there are these orexins or hypocretins, which are also neurotransmitters, which are localized in the dorsolateral hypothalamus, which also have neurons projecting widely throughout the brain, which also seem to be related to arousal or wakefulness. But interestingly, they also seem to control this transition between sleep and wakefulness in such a way that they maintain an equilibrium that's constant or static. So instead of sort of flip-flopping between sleep and wakefulness, these orexins or hypocretins maintain a stability between sleep and wakefulness over time. But in any case, their net effect is to be arousing or activating for the most part. Interestingly, these neurotransmitters also seem to mediate other areas such as locomotion, metabolism, even blood pressure, and satiety. So it's a fascinating group of neurotransmitters. Anyway, so the thought has been that since they promote arousal, by antagonizing them, we may be able to produce sleep. And in fact, it turns out that these medications, which are orexin receptor antagonists, seem to be sleep-promoting neurotransmitters. Interestingly, the absence of these orexins in the central nervous system is something which is responsible for narcolepsy, which is, of course, a condition which is characterized by a significant amount of wakefulness. So these dual orexin receptor antagonists are the agents which seem to be helpful in terms of treating insomnia.
Well, that is really fascinating. So by antagonizing these wakefulness-promoting chemicals, if you will, you sort of tell the brain, hey, it's time to go to sleep. I mean, in some ways, it sounds like melatonin. What's the relationship between melatonin and the orexin system?
Good question. Melatonin serves two purposes. One is sleep promoting, and the other is rhythm setting. So it's sort of the neurotransmitter which tells the rest of the body what time it is in the outside world. It's a sort of a signal secreted by the pineal gland, which in turn is responding to the suprachiasmatic nucleus. So really melatonin, at least in animals, is a rhythm-setting hormone, and it tends to also have some sleep-promoting properties. But it's not related directly to the orexins, which are more wakefulness, sort of general wakefulness-promoting neurotransmitters.
Right. Well, let's just detour for a quick second. I meant to do this. You mentioned Ramelteon earlier. Ramelteon works as an agonist at melatonin receptors. Is that correct?
Exactly. It is not itself melatonin, but it promotes melatonergic activity. And it doesn't seem to have a lot of rhythm setting potential. It has not been well studied for that, but is more relevant in terms of sleep promotion. And it's one of the few hypnotic medications which is not scheduled. It does not seem to be in any way, shape, or form promoting of addictive type behavior. The second hypnotic, by the way, in that sort of category is doxepin, low-dose doxepin, which is indicated for maintenance insomnia, which is also not scheduled.
Yeah. And while we're mentioning that, trazodone, which people use quite a bit, is not approved for sleep, obviously. But so that's a very important point, Karl. I think these are not scheduled drugs, whereas all of the benzodiazepines and the Z drugs that we talked about are scheduled. And now these orexin drugs have been scheduled.
They very much are. And simply as I think a product of the basic animal studies, which showed some degree of self-reinforcement in these drugs.
Even the orexin antagonists. That's interesting. Yes. Okay. Let's finish our little detour with melatonin. You know, a lot of people take over-the-counter melatonin, and there's a debate I've heard about when to actually take it. Should you take it when the sun goes down? Should you take it at bedtime? What would you say about that?
Yeah, I think like any complex question, the answer is it depends, right?
Depends. Okay.
So I think if the patient has primarily a circadian rhythm disturbance or a chronobiologic disturbance, then the timing of the administration becomes very relevant. So in delayed sleep phase syndrome, these are primarily adolescents who, like in the case of your son, who may have difficulty falling asleep. Who may have difficulty falling asleep or go to bed or fall asleep at 2 or 3 in the morning, then kind of a delayed waking time the next morning. Administering the drug 4 or 5 hours prior to bedtime at a very low dose seems to be helpful. So 0.5 milligram or 1 milligram of melatonin around maybe 8 or 9 p.m. Whereas a person who's having simply difficulty with insomnia, the average, if you will, insomniac, a higher dose at bedtime would be better.
Well, that's extremely helpful. Yeah. Thank you. And then, of course, there's controlled release melatonin, which never made a lot of sense to me. But so is it immediate release good enough?
I think for the circadian rhythm abnormalities, probably yes, definitely. But, if it's a problem with maintenance insomnia, then there may be a point to control release melatonin, although the studies have never been done on that, unfortunately.
All right. Okay, well, let's now move on to this newer category, the orexin drugs. There are currently 3 on the market. How do we think about these 3 different medications? They're all dual antagonists, meaning they block the orexin 1 and orexin 2 receptors. Am I correct?
That is correct. The precise role and function of these various orexin receptors is not, at this point at least, one which is of clinical relevance, but the 3 drugs are suvorexant, lemborexant, and the most recently introduced, the ritorexant, the daridorexant. And they really all are mechanistically very similar. The differences, and I don't think there are at least meaningful differences as far as we know currently pharmacologically, but there are some differences in what types of different type of applications these drugs have been studied for. And in terms of safety and in terms of side effects. But generally speaking, these are very similar medications.
So the difference is mostly pharmacokinetics. Is that correct?
Yeah, but again, I don't think they make the pharmacokinetics, as far as I can tell, have made any significant impact in terms of how we would use one drug versus the other.
Okay. Are there any differences with respect to the affinities for the orexin receptors or the balance between binding to orexin 1 versus orexin 2 receptors?
That's a good question, and not that I know of, or at least not something which is necessarily of clinical relevance for us.
You haven't seen anything. There is a category, of course, of drugs. There are SORAs in development that bind to one or the other of the orexin receptors.
Yeah, we'll find out how those are relevant, right? Hopefully.
Yeah, it's hard to tell, but I know one in particular, seltorexin, is being looked at even for insomnia associated with depression and maybe even for depression itself.
Right.
So
very
as
interesting.
Before, it's really interesting. The orexin system may be involved with mood as well, as is the melatonin system.
Right.
These are such complicated relationships. So again, let's just be clear. These orexin antagonists, they do not bind to GABA receptors. Is that correct? They don't have anything to do with GABA per se, do they?
Yeah, that's a good point, Andy. And that is correct. And as you well know, GABA is the most frequently distributed receptor in the brain.
Yeah.
And has a wide array of effects throughout the nervous system, inhibitory in nature. So GABA receptors are involved in promoting anxiolysis on the positive end, also sleep, but they can also promote myelorelaxation as well as cognitive disturbances. And so simply promoting GABA may have a complex set of effects which may not be necessarily desirable and may be viewed as being a side effect in nature. The orexin receptor antagonists seem to be more selective in the sense that they are targeting sleep mechanisms primarily, maybe a few other things as well, but certainly not along the lines of the wide array of side effects which we would not want to have. Now, could they have side effects? And the answer is absolutely yes. In fact, the studies have shown that orexin receptor antagonists do produce some daytime impairment in the morning in some individuals after awakening in terms of sleepiness or in terms of cognitive disturbance. But on the order of effect, although not directly compared, these seem to be less than what we would anticipate from certainly the long-acting benzodiazepines that we talked about earlier.
Right. So it seems like these drugs, just in my blunt way of thinking about it, that they're a little more selective, a little cleaner, if you will, a little less collateral damage. Is that one way of thinking about it?
I think so. Certainly we can think of them that way, but in all fairness, they've not been directly compared to the benzos in that regard. So theoretically, at least, they seem to have that advantage.
Yeah. Now, we did mention daridorexant, the newest one, did use the daytime scale, the ISDIC. Or IDZIC, sorry, I should say it correctly.
Yes.
The other two didn't. I know that there are some differences in daytime sedation reported side effects, not huge differences, but is there something to this? Should we be thinking about daridorexant differently from the other two?
So, the difference really is maybe a product of how it was studied. I'm not sure if there is an actual clinical difference, but daridorexant was studied relative to a scale which is used to assess daytime dysfunction, and did show, compared to placebo, there was an advantage to daridorexant in terms of the level of daytime sedation on the scale. But now, remember, this was a secondary outcome measure, not the primary outcome measure used for this medication. But nevertheless, it's a very interesting finding. That same scale was not utilized in the other orexin receptor antagonists, so we don't know whether or not they may have produced similar effects or not.
So there is some language, I think, around that they're able to say in a promotional setting, of course. And I realize you've got to look for the advantages. The different companies are going to look for their advantages here and there.
Right.
There are some pharmacokinetic differences just as far as half-lives and things like that. But as you said, we don't know if that truly translates into
exactly
benefit or not. So how are we to choose amongst the three of them? Or should we just get comfortable with one and maybe switch if we need to? How should we think about that?
I think at this point, that seems to be the way to go. I think certainly payers may also determine for us which one we go to versus another. Yeah. Unfortunately, in this day and age, that's very relevant. Yeah. A couple of other things to think about. I think that in terms of long-term side effects, withdrawal rebound, that is a rapid rebound insomnia or withdrawal symptoms after rapid discontinuation, suvorexant and lemborexant have been studied for up to 3 months and 1 year respectively. So they seem to have some benefit in that regard. In terms of waking up in the middle of the night, both suvorexant and lemborexant conducted studies with elderly as well as normal age individuals and showed no effect on memory and no effect on balance after rapidly awakening in the middle of the night. Again, you certainly want to be careful, but those are things which are positive effects. There were also a set of studies both with suvorexant and lemborexant in terms of next morning, after waking up the next morning. And neither of them showed impairment in terms of memory or word recall. With the ritorexant, next day driving was not impaired compared to placebo in patients who woke up and drove the next morning. Again, I think these are all wonderful features, but we should always, of course, remember to warn our patients against the possibility of these things happening because individual patients can have different effects.
Well, it sounds like perhaps they have less liability for those things than the benzos and the Z drugs.
Certainly seems that way, although not directly compared. Yep.
Yeah, again, good point. And then, as you mentioned, we're certainly all familiar with the problems with coming off of benzodiazepines or the Z drugs. If people use them chronically, there's withdrawal effects, rebound effects, as you said. And so perhaps there's a little less of that with the orexin antagonists.
Possibly so. Again, not directly compared, but it certainly does seem that way. I would certainly, regardless of which medication is used, I would certainly favor a very gradual withdrawal process, no matter which medication we're thinking about taking the patient off of over the course of time.
Well, you're reading my mind, and my next question is how to transition from the benzodiazepines to the orexin drugs. What would you say? What would you recommend?
Well, I think slowly is the way to go. So as the orexin receptor antagonists probably do not accommodate for withdrawal effects from the Z drugs. So I think very slowly going downwards on the Z drug and at the same time introducing the orexin receptor antagonist may be the way to go. So zolpidem, 5 milligrams, maybe 2.5 milligrams, and then at that point adding the orexin receptor antagonist at a low dose and then increasing gradually may be the way to go. The other way, of course, is to introduce cognitive behavioral therapy. Yep. He's been shown to be effective for diminishing the use of the hypnotic medication.
We have to come back to that. We've got to remind people of that. I think that's very wise. So what it sounds like you're advocating is a classic cross-taper type strategy. Is that fair to say? So
that's what I do.
Some degree of overlap. Yeah. So it's not a clean break. You don't taper completely off of one before starting the other. It's safe to overlap to some degree?
Yeah, well, again, that practice has never been really measured scientifically, but that's what I favor. I think one of the things with insomnia patients is that they rely so much on these medications. The prospect of going off of a sleep medication fills them with so much anxiety that just that produces even more insomnia. So having something to take every night in and of itself has psychologically a positive effect.
Certainly. Yeah, almost like a crutch, yeah.
Exactly.
Certainly. I'm just wondering, we talked a little bit about the side effect profiles here. Besides perhaps a little bit of daytime of carryover sedation or something, are there any other side effects to watch out for with the orexin drugs?
Yeah, I think the memory disturbance and so on, but in narcoleptic patients, they're contraindicated because they may produce parasomnia. So it's not easy to imagine putting a narcolepsy patient on one of these drugs, but I have seen some narcoleptics who come in with so much sleep disturbance that actually they sometimes warrant a sleep medication during the night. But these medications are contraindicated in that population. But certainly impaired alertness, motor coordination, compromised respiratory function is a possibility, although the drugs that have been studied in that regard, all of the orexin receptor antagonists, have shown very favorable profiles in that regard. And they are DEA Schedule 4. So if a person who has a significant degree of drug use issues, we may have to be a bit more careful with the population.
So that's the same level of scheduling as the benzodiazepines and the Z drugs.
Exactly.
They're all scheduled.
Exactly.
Okay, well, that's important to realize, certainly. Okay, so are there any other drug interactions or any other concerns we should have with the orexin antagonists?
Well, clinical characteristics of patients, we talked a little bit about age. We talked about patients with a history of substance use, abuse, being careful there. People who are shift workers who need to get up in the middle of the night and get up out of bed. We talked a little bit about that, but certainly we need to be careful about putting them on these medications. People with significant respiratory compromise. Be careful about these drugs. I mean, I think that they have this, some are safer than others, but we need to be careful there as well. Pregnancy, they are contraindicated. They're certainly Schedule C. I would not use any of these drugs in the context of pregnancy unless you're very careful about that possibility.
That's a very important question, if I could interrupt you there, Karl. What do you prescribe during pregnancy for insomnia?
Well, I tell all pregnant women that it's my personal preference that they not take any hypnotic medication once pregnant, especially during the first trimester. And there's where CBT is very important, right? Patients with significant liver impairment, in some cases kidney impairment as well, we have to be careful.
Okay, great. So these drugs, though, are these drugs approved for long-term use, for chronic use, or just for shorter-term use?
Yeah, so in the drugs introduced more recently, the Z drugs, as well as the orexin receptor antagonist, Ramelteon, and the histamine receptor antagonist, there's no limitation on how long they can be used for. So many of them have been used there have been studies with these drugs, controlled studies, over the course of not just a few months, but also over the course of even 1 year, showing minimal development of tolerance, no rebound after rapid withdrawal. So there's nothing in the indication for these newer drugs that suggests they should be taken away within a few weeks or a month or whatever. So we certainly can use them indefinitely if we need to. But you made the point earlier how we should not do so unless the patient needs to continue these drugs for long periods of time. So yeah, there's nothing that says you should stop a drug after a month. But also there's nothing that says that you should continue the drug indefinitely. So there's where clinical judgment comes into play. And I've seen so many patients who have come to me referred, or rather come to me because of the treatment by their host physicians who said to them, look, I can only give you a month's worth of this drug and then you have to discontinue. They really needed the medications and come to me in very anxious state saying, look, I need something. I can't not have anything. So I do think that we have to really look at the patient's clinical situation. Not sleeping itself could be much worse and more detrimental for a patient than the side effect of a sleep medication. So,
certainly.
Yeah.
Is there a medication you mentioned respiratory compromise. Is there an insomnia medication that's safe to prescribe to someone with sleep apnea in particular? I'd be a little concerned about that.
Yeah. Well, the medications that have been looked at in the context of sleep apnea are Ramelteon, let's see now, they're retorexant, lemborexant, suvorexant. They have very slight degrees of impairment, clinically insignificant in OSA patients, and some in mild apnea, some in moderate apnea, but none in severe apnea patients. But I do think that in the context of apnea, it's important to advise our apnea patients, look, you should always use your CPAP machine or have adequate treatment of apnea when you're taking a sleep medication.
Yeah, that's certainly wise advice. Now, I realize you've mentioned there have not been head-to-head studies of the orexin antagonist versus the benzos and the Z drugs, but it just kind of intuitively seems to me that there is a slightly better safety profile here. There's a better margin for safety, if you will. How do we go to battle? I realize this is beyond the scope of our talk, but here, how do we go to battle with insurance companies when we're trying to use these newer agents that may have some, if nothing else, safety advantages?
Yeah, I mean, that's a good question, Ed. I think it becomes a very difficult thing in most cases. My own personal experience has been that the attempt to convince an insurance company representative that one drug is safer than the other generally does not work unless there's incredibly solid evidence comparing one drug to the other. So that's been difficult for me. On the other hand, many will allow the use of a safer drug if the first drug were used to some extent. And they don't specify how long that drug should be used for. So if you use one drug and it fails, and go into the next tier drug is sometimes allowed. So there's where I think the art of getting these drugs approved comes in. I don't have any solid wisdom to offer in that regard, unfortunately.
No, you said something interesting. It sounds like you're saying an efficacy argument goes a little better than a safety argument to some degree, if you say.
It seems to. At least they're tiers. If one drug is tried, does not work, and then the other is allowed. That's right. Mm-hmm. Yeah.
Well, I'm sure most of our audience is quite familiar with how to do what is necessary to do to deal with, such as making sure that the patient fills the prescription, because nowadays that can be monitored. These things are all online. So that's very helpful. Okay, circling back, we did a podcast with the company that makes the FDA-cleared PDT for insomnia. That's the prescription digital therapy. And I'm just wondering, it makes a lot of sense to me that might be something that people might want to consider using, especially if we're thinking that it's not necessarily an either-or situation. It could be used with the medications. What is your thoughts on the prescription digital approaches here?
I do agree. We don't have a ton of experience with these because we have our own cognitive behavioral therapists in our academic institution where I work, which is a wonderful luxury. Yeah. But I do certainly think that in community settings and places where these types of specialists are not available, I do think that's an excellent choice. For all the reasons we talked about where one would use CBTI. The issue that comes up there is one of insurance approval and support. I'm not sure to what extent those are supported by insurance companies.
Yeah, that's always an issue, I guess, for all our therapies. So are there any other interventions on the horizon or that are being studied? Anything else we need to be aware of?
Yeah, certainly I think there are all these devices. You already mentioned a number of them. An interesting device which came out a couple of years ago is a head cooling device for insomnia. It's comprised of a cap that's put on the head, and it diminishes the temperature of the skin around the skull. And some interesting data showed that it does have a modestly but positive effect on insomnia. So I think we'll be seeing more and more of these devices. There are a number of devices which actually produce tone, a soothing type of tone to the brain. There's alpha stimulation therapy. And from the standpoint of pharmacology, we may be seeing the introduction of cannabinoids, although cannabis itself has never been shown really conclusively to improve sleep. It certainly does seem to be a fairly good anti-anxiety agent and a nociceptive agent. So along those lines, patients who suffer from anxiety and pain disturbances seem to benefit indirectly from sleep and anecdotal data. So that may be something we may be seeing developed for sleep directly. Angiotensin 2 receptor antagonists are being developed. There's drugs which specifically target the nociceptive orphanin, Q peptide, NOP receptor partial agonists are being developed as well. That category of drugs may also be helpful for depression as well as substance use. 5-HT2A receptor antagonists, as some of the older antidepressants, are actually antagonize the postsynaptic 5-HT2A receptor.
Exactly, the two.
And that's being selectively looked at as an area for insomnia as well. Adenosine agonists,
I was going to mention adenosine because of caffeine's effects. It's the obvious choice,
Exactly. They're being developed. I don't know how far off some of these are, but I'm certainly hoping they're not that far off. We could use as much help as we can get with insomnia.
Yeah, I think so. You mentioned the elephant in the living room, and I forgot to bring this up, and that was THC, marijuana, cannabinoids, if you will. There are some patients who do swear by it.
Absolutely.
It's interesting. The data for psychiatric indications is not good. As you mentioned, for pain and nausea, there's very strong evidence. For insomnia and certainly for anxiety, it's very mixed. I mean, there's some patients who seem to have angiogenesis, more anxiety from it. But
and you might know more about this than I do, but have the studies have well-formed and methodologically sound studies been done with anxiety with the cannabinoids, to your knowledge?
Yeah, that's a great question. Most of them are not large numbers. Most of them are not necessarily the most carefully controlled. And part of it is around the issue of working with THC and cannabinoids. There, as you well know, there's many cannabinoids. When you smoke marijuana, there's probably hundreds of cannabinoids. And so there's always the question of which cannabinoids do you study, what potency of THC.
Right.
So these studies have certainly varied with respect to that. As we know, the marijuana on the street today is very different from what it was several years ago, with much higher concentrations of THC. So it's been hard to standardize things. So you're right. We could compare and contrast the methodological issues. We all have patients who swear by them, and they use the marijuana, and it's now so easy. In some states, it's you walk into a formulary and you get it for recreational use. You don't even need medical card. So we have to confront marijuana. Now, There are pharmacokinetic considerations with marijuana. As you probably know, marijuana is a CYP3A4 inhibitor, both the THC and the CBD components. And THC also inhibits CYP2C19. So that can certainly have some pharmacokinetic interactions with medicine. We have to be aware of.
Interesting.
Yeah, it really is. It's an area that we'll keep our eyes open for. But in the meantime, we do have options. And Karl, I really want to thank you for helping us sort through these things and think through the assessment and the management of insomnia. I've learned quite a bit here today, and I really appreciate it. Any other final words that you'd like to help our audience with when they're thinking about insomnia?
No, I do think stressing some of the critical points that we made today. So, number one, looking for insomnia or asking about it in the routine settings is important and relevant. And when a person has insomnia, to perform a systematic evaluation clinically. I think we've talked a lot about that, but sort of isolating the peripheral insomnias from the very highly comorbid ones would be very relevant. And then to treat the comorbidities as such, a lot of times that also really diminishes the insomnia severity. Mm-hmm. And then I think that getting into the specific treatment of insomnia itself, tailoring the treatment to the patient's clinical characteristics makes a lot of sense. And developing a way in which we can administer CBT ourselves, or developing a referral network of CBT therapists, or using some of the online CBT digital formats would be really important, I think, for us to when we treat insomnia.
Do you recommend sleep diaries? I forgot to ask you that.
Yeah, we talked about actigraphy a bit, but I do think that a diary is helpful to look at the course of insomnia or its pattern over time. You really want to see that is this a delayed sleep phase or advanced sleep phase or something along those lines. So I think it's a good idea. If you do have the luxury of time, if you can bring the patient back 2 or 4 weeks later and ask them to fill a diary, that's often helpful.
And you mentioned there are various apps now that can help with these kinds of things, tracking and things like that.
Yes. Yep.
And one final thought I guess I would have, I've always been surprised, Karl. I call this my shopping bag trick. I have a patient fill up a shopping bag with every pill bottle in their house and everything they're taking, prescription or over the counter. I'm consistently surprised when I see what they're taking. Very often there may be something there that's interfering with sleep, or there may be a drug interaction that wasn't aware of. I've actually literally, Karl, had patients taking, there's 2 bottles. One has the brand name on it, one has the generic name, and they're taking both. It's the same medicine.
Oh, my goodness.
So I think that's also wise to really try to get an accurate list. Now, it's a little easier now sometimes with the prescription drug monitoring programs where you can see everything that a patient's been prescribed by other providers.
Yeah, but certainly, to your point, the non-prescribed medications don't make it to that list. So,
what is surprising, now that we mention it, there are several over-the-counter supplements that have what I call caffeine in disguise, or stimulants in disguise, as well as alkaloids and things like that. Guarana seed is essentially caffeine. People don't realize that, for instance. Yeah. Well, again, I really want to thank you for your time, Karl. It's wonderful talking to a fellow Philadelphian, and I really enjoyed it. And I want to thank the audience. Hope this was helpful to you. And I want to encourage you to check out our other podcast offerings, the NEI podcast, wherever you get your podcasts. And this is a CME program, so remember to follow the CME instructions. And for more information on our podcasts and our various other educational offerings, you can go to the Neuroscience Education Institute website, which is www.neiglobal.com. That's www.neiglobal.com. And so this is Andy Cutler saying thank you very much. And thank you, Karl. Appreciate your time.
Thank you.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.